my favorite lecture. That doesn't mean it's my best lecture. It's a hard thing to do. Okay, that looks all right. So, those are the 4 estrogens. 2 of them you never see. Certainly estetrol, you never see unless you're pregnant. Are those all right? Turns out, I just learned this at this conference in France I was at. Turns out estrone is important. They all bind the estrogen receptor. Estrone is important because it's more stable. I just learned this in France at this conference I was at. But who knows why it would be more stable? Makes sense if you think about it.
Double bond on the oxygen.
Why would that make it more stable? Yes, you are correct.
But less likely for one of those a double bond to break rather than a single bond.
Not quite.
Resonance.
What?
Resonance.
Does what?
Resonance.
No. Well, maybe. I'm not good enough chemist to know if that's true. Huh?
This is more active than more.
I know, but why? It has a longer half-life. Why is ethinyl estradiol more stable? 17 ethinyl estradiol. Steric hindrance from what? How do you degrade estrogen? You put like a glucose or sulfate group on the 17 position. So ethinyl estradiol, the steric hindrance it makes it more difficult to do that. If you're estrone, you can't put that glucose and that sulfate on here. So this is actually a more stable molecule. I think it binds the estrogen receptor with a little less affinity, but it's more stable, so that makes it more potent than estradiol. Estestrol is important because I literally just learned this today. You got brand new stuff. Estestrol is important. It binds ER alpha, binds the estrogen receptor. However, it does not bind SHBG, and it does not induce SHBG like the other estrogens do. Yeah, I can't repeat that. And I'm going to ask you why that's important. Estetrol binds the ER, the estrogen receptor, not ER, the endoplasmic reticulum, the estrogen receptor, just like all the estrogens don't do. But it does not induce SHBG, sex hormone binding globulin, and it does not bind to sex hormone binding globulin. Why is that important? What? Yeah. So now you have more free estrogen. Those other ones are bound to SHBG. Estrone has a longer half-life, but the special estrogen that only comes from the fetal liver, not only is it an estrogen, but it's free. It cannot be bound by SHBG, and it does not induce. Those other estrogens induce SHBG. So it does the same thing as the other estrogens, but it's adding a little boost. Now, why do you want to do that? What you can imagine is happening, or not, you don't have to imagine, I'm telling you, is one, because the baby's adrenal gland grows, progesterone starts to decline. The baby's telling mom, it's time to move. At the same time, because what I just told you here, let me get up this topic. These estrogens are starting to increase relative to progesterone. Remember, progesterone was predominating. Now progesterone's going down, and estrogen's starting to go up, relatively speaking. Why is that important? Here's why that's important. Estrogen increases prolactin secretion. And estrogen increases the prolactin receptor in the breast. Why is that important? That's important because, well, wait, let me tell you how it does it first. I just learned this today. Because remember, dopamine is suppressing prolactin. Progesterone does too. You don't want to be making milk when you're trying to make a baby. Baby ain't gonna eat for 9 months. Why you gotta make milk? It's gonna be spoiled by the time they come out. So it's been suppressed by dopamine. But estrogen stimulates the lactotrophs. You know the word lactotrope? Right? You learned that last part. It stimulates the lactotrophs to make and release more prolactin. It stimulates the lactotrophs, estrogen, stimulates the lactotrophs to make and release more prolactin. It stimulates the prolactin receptor in the mammary gland. It stimulates the lactotrophs to release more prolactin, and it causes some somatotrophs to switch over and become lactotrophs. It recruits cells that normally make growth hormone, and they switch over and start making prolactin. So even the dopamine might be still inhibitory. Estrogen's telling the lactotrophs to make more, and it's telling the growth hormone, you don't need to grow, make some prolactin. Here's what else it does. I didn't know this till today. Estrogen increases TRH, and TRH stimulates the lactotrophs. So it's also a prolactin-releasing hormone. I literally didn't know that till today. Okay, I'm going to say those 3 things again. Estrogen causes the lactotrophs to secrete more prolactin. Estrogen causes some of the somatotrophs, the growth hormone secreting cells, to start making prolactin. And estrogen stimulates TRH, which stimulates the old and the newly recruited lactotrophs. It's also making the breast more sensitive to prolactin. Prolactin increases its own receptor, transcription of its own receptor. It increases your blood sugar. I'm going to tell you a funny story. Actually, it's not funny. But prolactin stops your liver from taking up sugar, from glucose. It stops your fat tissue from taking up fat so that it's now free in the blood. Why on earth would you do that? Somebody give me something. Give me something.
Provide nutrients to the baby.
No, well, it can do that. But why else? What does prolactin mean? It's the prolactational hormone. Got to make milk. Milk is sugar, lactose, with glucose and a galactose. Milk is fat, and some of that's used in the breast to make protein, whey and casein. Curds and whey. So it's making these nutrients available so that mom can make milk. It also increases ductal and alveolar growth. I'll show you what that is in a minute. I'll tell you a story while you take that all away. He said provide nutrients to the baby. So some women, including my wife in the first pregnancy, some women are really sensitive to prolactin. And so they end up with something called gestational diabetes. And there's several problems with gestational diabetes. One is it causes preeclampsia. Who knows what preeclampsia is? What? Hypertension. Good. When you're a doctor and you have a pregnant woman in your office and she has don't even say hypertension, just say high blood pressure. Because the doctor walked in and he told my wife she had preeclampsia, which just means high blood pressure. But preeclampsia sounds like a venereal disease. And my wife went to Harvard, she got an MBA and an MPH and a PhD, but she didn't know what it was. She looked at me like, would you give me preeclampsia? Why? Why couldn't she have just said you have high blood pressure? Because you're worried about everything. Remember that when you're a doctor working with people. Just use regular words. So, if glucose goes up, you can get high blood pressure. That's bad for mom. Your blood volume's already high anyway. But the other danger untreated is, what's your name again?
Dan.
Dan. I was going to call you Brian. I'll call you Dan. The other problem is that excess glucose goes to the baby. And that makes the baby's insulin go way up. And you have a giant baby because it's got all those glucose. Insulin's like the growth hormone. And so you get up with a giant baby. So one, mom's now at risk when you try to deliver the giant baby. Two, as soon as the baby's born, as soon as you cut the cord, there's now no more glucose, but there's still a lot of insulin. So the baby can go into hypoglycemic coma. So they screen for this right away. The treatment is insulin injection. I used to have to inject insulin in my wife's belly. I hate needles. Unless I'm sticking them in a frog, but in people. So gestational diabetes. And it doesn't mean you won't have it with every pregnancy. And it doesn't mean necessarily that you have diabetes of any other type. There's no correlation. Yes? I was trying to think of what I'm going to say next. Sharon. It's Sharon, right? Okay.
So, gestational diabetes is caused by the prolactin.
It's because prolactin is trying to block you from taking up sugar from the liver. So for whatever reason, some women are really sensitive to the prolactin, not every pregnancy, and so the sugar and then the insulin doesn't respond enough. And so again, that high glucose in the blood can cause high blood pressure or preeclampsia, if you want a fancy word. And then also that excess glucose can go to the baby and generate an oversized baby, and if untreated, back in the day, the baby would go into hypoglycemic coma and die because it has really high insulin and all of a sudden it's really high glucose. It's cut off once it's born. Yeah.
You also mentioned about dopamine.
About what?
About dopamine.
Oh, normally dopamine is suppressing prolactin. But under these conditions, dopamine can't do the job because estrogen is stimulating the lactotroph. Estrogen's recruited more lactotropes. And if you don't want to breastfeed, for example, they give you, is it bromocriptone they give you? But they give you some kind of dopamine agonist to actually stop you from lactating. Because you'll see, it's really painful if you lactate and don't breastfeed. We'll talk about why in a second. Yeah?
So is dopamine still negatively feedback, but there's...
It's not negative feedback, it's feed forward, remember, because dopamine comes from the hypothalamus.
Oh, yeah.
So dopamine's still present, but it's being countered by estrogen stimulating the lactotrophs and by estrogen recruiting new lactotrophs. So you get a net increase in prolactin. And that prolactin does all the things that I said. It also will ultimately decrease LH. So if you continue to breastfeed after the baby's born, you'll have something called lactational amenorrhea. That's the same problem we have with the hyperprolactinemia. And it's involved in some maternal behaviors. And I read today that it decreases libido. Guess what else is happening? I just learned this today too.
Shouldn't it be doing something to your uterus?
What?
Shouldn't prolactin have some effect on your uterus?
I'll tell you what's happening in uterus in just a second. The other thing that's happening is, now that estrogen's going up, TRH is going up. TRH also does what? Stimulates TSH. The TSH stimulates more thyroid hormone, which the baby still needs. And estrogen also stimulates TBG. I literally just learned this today, so let me tell you what that means. Baby still needs thyroid hormone. It can make its own, but it still needs thyroid hormone. The HCG, which was stimulating the thyroid hormone, is gone. So the baby now has a new way of hijacking the thyroid axis. The estrogen stimulates TRH, so the axis is now being stimulated. The estrogen also from the liver stimulates TBG, so now a lot of the thyroid hormone is bound, so it's not free to go back and do negative feedback. So the estrogen has knocked out the negative feedback, so mom's making more and more thyroid hormone without the HPT knowing about it. So the estrogen is stimulating the TRH, which is stimulating the prolactin, of course. The TRH is also stimulating the TSH, but the estrogen is also stimulating TBG. So most of that thyroid hormone is bound, but remember the baby has a high affinity binding protein. It can still grab it and take it from mom without mom's negative feedback system knowing that it's actually made more thyroid hormone. This is like the coolest thing ever, isn't it? Yeah.
You said that once that HPG is gone.
The HPG is not active because progesterone all this time has had a negative feedback effect. And now on top of that, you got prolactin now knocking out the LH so that you don't get pregnant when you're pregnant. Now let's review. Wait, let me see. We still have to go in later. Oh, we're good. We will deliver today. So you started out, the first hijacking by the placenta was to make this HCG, which hijacked both the thyroid axis and the ovary. The ovary dies anyway, the HCG stops. So now the placenta takes over making progesterone by stealing cholesterol from mom. Then you maintain that second trimester. Then the adrenal gland grows. And the adrenal gland they know, but you know what I mean. The adrenal gland starts making cortisol and aldosterone because you can't live outside of the womb without aldosterone. You can't breathe outside of the room without cortisol. Same thing happens in metamorphosis with tadpoles. You don't care. That's kind of cool. Then the fetal adrenal zone grows, and the fetal adrenal zone starts making this DHEA sulfate, which the placenta uses to make 3 estrogens. Baby says, that's not enough. I need an extra estrogen that won't bind the SHBG. It takes the estriol back, turns it into E4, sends it back to mom. Now you got an estrogen that does not bind or does not stimulate SHBG. You want to know the funniest part about this whole thing? I don't know if it's true or not. Because that was a few years ago, I was at this party. And I was talking to this woman, she was an MD, PhD at UCSF, and I was talking about my research, and she probably didn't care. And she was talking about her, she said, oh, I'm studying the maternal fetal placental unit. I said, but that's like textbook stuff, everybody knows that. She said, no, not in humans, that's all only known in sheep. So apparently we all know this from sheep, at least at the last time I talked to her. It wasn't clear this was known in humans, so I just thought I'd share it with you. It's a little glimpse into the future. Like right now, when you go to a frat party, slam a few brews, some Jaeger, or Fireball, talk about the big game. 10 years from now, you'll go to the cocktail party, sip Chardonnay, and talk about maternal fetal placental unit. That's what you got to look forward to. So that's where we're at. Then, we're not done yet. Because see what's happening is, the baby, the progesterone's going down, the baby has prepared itself, the adrenal gland, for delivery. Cortisol for the lungs, aldosterone for the kidneys to maintain the sodium. The baby is taking the progesterone away, it's ending the pregnancy. And it sent estradiol to mom to start preparing its first meal. He's gonna be hungry. She's gonna be hungry when she come out. Because the endocrine parasite is going from 9 months as an endoparasite to up to 3 years as an ectoparasite. And apparently an undetermined amount of time as a financial parasite. I'm only joking, I love my kids. But let me show you what's happening in the breast. And then we're gonna deliver this baby. You know, I'm just gonna go ahead and apologize ahead of time. Because I talk with my hands. So when I'm talking about mammary glands, like I usually try to talk like this, and people all complain. In fact, when my son was little, up to 10 years old, when I walk into school, he'll hold my hand. And I thought it was sweet, because of no macho stuff. And then finally he said, no, Dad, it's because you're embarrassing because you walk around going like this. This is 100% true story. I'm walking to school this morning, and I was like talking about maternal fetal placental unit. And this woman on the bike was like, oh, good morning. No, it wasn't waving at me. Now I understand my son's issues. So, the alveolar cells are these ones that are kind of in this sac. And then this sac is connected to ducts, and that's where the milk comes out. So it's just like a salivary gland. And so when you're not pregnant, before you're pregnant, the bulk of the size of your breast is this fat pad. Has nothing to do with how well you can feed a baby. And in fact, when you get a breast implant, they're replacing the fat pad with whatever size you want. It has nothing to do with how much you can feed a baby. Of course, most guys are walking around looking at breasts for other reasons. I'm like, wow, you can feed somebody for 3 years. That's what I think. That's what I think. So what estrogen does is estrogen maintains these ducts. But prolactin comes in, and in addition to these metabolic effects causing you to release the glucose in the fat, prolactin stimulates the cells, the alveolar cells, and these ducts. And it stimulates them to start making milk, which fill up in these sacs. So towards the end of pregnancy, as estrogen increases and prolactin increases, and the breasts grow. In fact, when you're lactating, they grow. They're a different shape, and that's because when you're not lactating, when you're not pregnant, the size of the breast is mostly this fat pad. But when you're pregnant, it's the ducts and the alveolar that are growing. And also, when they fill up with milk, the size of the breast will change. Cortisol from the baby is also important. What do you think cortisol does? What does cortisol mean? Let me tell you guys what it means. If you had to guess, what do you think it means? Cortisol. Somebody guess. Either guess or bring a cricket. What do you think it means? Cortisol. The all probably comes from the alcohol in the 17th position. The cort refers to as a cort from the cortex. It's a glucocorticoid. So what do you think that means? As opposed to a mineralocorticoid.
Regulates glucose level.
Well, break the word down for me. Oid means it's a steroid. Corticoid because it comes from the cortex. And you're right, it regulates glucose. So as in cortisol's going up from the baby's adrenal gland, it's also helping with milk production because cortisol causes you to burn and release fat and sugar as a glucocorticoid. So along with prolactin, cortisol is helping the breast tissue take up free fatty acids, amino acids, and simple sugars, and what comes out milk fat, cream. And prolactin itself is stimulating the cells along the sac and along the duct. Does that all make sense? Yeah.
When you said what cortisol does, or what it helps do?
As a glucocorticoid, cortisol doesn't want you to store anything. It wants you to burn and release free fatty acids, so it wants you to catabolize and release free fatty acids. And it also wants you to release sugars. And that sugar and fat are what are being used to make the components of milk.
Are the proportional components of milk controlled by hormones?
Yep. Wait. I do not know the answer to that. You're asking because the first milk is colostrum. It's kind of a different content than the later milk. I don't know if it's hormone controlled. My guess is yes, it's hormone controlled. But I don't know. Well, actually maybe, because after the baby's born, this is all going to be maintained just by prolactin. Because you won't have the cortisol coming from the mom, you won't have the estrogen, you'll have just prolactin. So it probably is. I mean, I know the content changes within a couple of weeks. The components change.
Is the cortisol from the mom or from the fetus?
Cortisol is mostly coming from the fetus. And some of that, well, you'll see in a second. So now, we have to get both the baby and the milk out. Estrogen also stimulates oxytocin, the hormone, and it stimulates oxytocin receptor in both the mammary gland and the uterus. The mammary gland like the uterus, is an endothelial layer surrounded by a myoepithelium. Same structure we talked about with blood vessels, same structures we talked about with the reproductive tract. Well, the uterus is part of the reproductive. Oh, I almost forgot one thing. The other thing estrogen does is it stimulates a hormone called relaxin. Relaxin comes from the corpus luteum. If you're an animal that maintains the corpus luteum all through pregnancy, if you're a primate like us, relaxin comes from the placenta. And relaxin induces, I use the word as a mask, but it's a pelvis. Relaxin induces collagenase and hyaluronidase. Relaxin induces two enzymes. It's in the insulin family. It looks like proinsulin. Completely independent receptor. It induces collagenases and hyaluronidases, and it causes the ligaments in the pelvis and the pubic symphysis. See this crack here? It causes those to loosen. I remember my mom, when my younger brother was born, she was always like wobbling and falling, because it causes a loosening of these ligaments, because the baby has to come through there. It makes this symphysis stretchy, because this has to stretch for the baby to come through. Yeah, go ahead.
Can you spell that?
Yeah.
Right?
Spell what? Collagenase? COLLAGENACE, ASE, and hyaluronidase, HY. I feel like I'm on a spelling bee show. Can you use it in a sentence, please? HYALURINIDASE, or something like that. But they're just the two enzymes that kind of break apart the ligaments so that your hip joints get loose and your pelvic symphysis gets loose. They come back. Then, the stretching of the uterus also causes an increase in oxytocin receptor. The stretching of the uterus causes an increase in oxytocin receptor. That's why, anybody here a twin? Anybody, were you born early?
Yeah.
That's because you got two babies, they take up more space. And even though they're not as big, they're stretching the uterus, and that makes you really sensitive to oxytocin. So usually twins are born early. My professor's twins were born like almost didn't live. I forget how small they were. But that's why twins are usually born early, because they stretch the uterus more. So you've got estrogen increasing oxytocin receptor. The babies also experience a big growth spurt, right? Because prolactin, just like Dan said there, because prolactin is causing more and more glucose, so the biggest, fastest growth is in the last trimester. And then, and I promise to tell you a funny story that's almost TMI. You start to have small contractions, like you have something called Braxton Hicks contractions. And eventually you get to the real contractions. And the real contractions are where, also the baby kicking, the baby moving. and stretching the uterus. We'll work that way. So the more active the baby becomes, the bigger it becomes, the more sensitive the uterus becomes. The uterus is becoming more sensitive because the estrogen is inducing the oxytocin receptor. But hopefully okay, because the baby's already making aldosterone and cortisol, you're already making milk. The uterus starts to stretch, it becomes more sensitive. Eventually you get to a contraction, which is very similar to what we talked about with orgasm. You get to a contraction that sends a neural signal to the posterior pituitary that causes the release of oxytocin. Oh, also I learned today, there's some oxytocin coming from the baby as well, through the umbilicus. I didn't know that. I just learned that today. So the baby's actually sending some oxytocin. What's that? Hijack number 40 or something like that. So the baby also starts to send oxytocin as it gets in her turn. And that contraction stimulates more oxytocin. That oxytocin stimulates another contraction. And the oxytocin is working exactly the same way we talked about during orgasm and ejaculation. And no, in my experience, having a baby is not like having an orgasm. But there are women who report like orgasmic type feelings with the contractions that are associated with having a baby. But the mechanism is exactly the same. In fact, here's a fun story I'll tell you. When you have your first baby, you drive back and forth to the hospital every other day because you think it's time, and the doctor's like, no, please stop coming, call first. And one of the things they always tell you is go home and have sex. And the idea is that if you have intercourse, the idea is that one, remember there's prostaglandins in the semen. Because you remember how oxytocin and prostaglandins work, right? So one idea is that the prostaglandins, which actually come from the seminal vesicle, not the prostate gland, will stimulate a contraction that will stimulate delivery. The other one is if you reach orgasm, those contractions of the uterus might stimulate more contractions and send you into labor. I actually asked our doctor if that actually works, and she says, no, probably not, but it makes you go home and forget about your baby. But the mechanisms are exactly the same. And the neat thing is, while you're delivering the baby, and you know how it works, right? Oxytocin binds, it stimulates the calcium, myosin light chain kinase, we're doing all that stuff. And the endothelium, it's stimulating the COX-2, which stimulates the prostaglandins, which stimulate more contractions, exactly like we've already talked about. And the cool thing is, as you're contracting the uterus to deliver the baby, milk's already shooting out. So the baby has its snack waiting on it while it's coming out. Because the same hormone is causing the uterus to contract is exactly the same way causing the myoepithelium of the mammary glands to contract. Exactly the same. If you have orgasm when you're lactating, milk will come out. And then after that, the lactation is maintained by prolactin. So as long as you're breastfeeding regularly, sorry, I talk with my hands. So as long as you're breastfeeding regularly, prolactin maintains milk production. Prolactin continues to decrease LH. So there's, like I said, there's lactational amenorrhea. In this country, no, it doesn't work. You have to breastfeed every couple of hours and not ovulate for 3 years. In this country, you do. The way that we do it, you'll probably get pregnant again. But the signal for the milk to come down comes from the baby. So just seeing the baby suckling, stimulating the nipple, causes more oxytocin to come down. Same mechanism we already talked about. And even the baby crying can cause mothers to actually eject milk. There's actually a Busta Rhymes song about that. You guys know that? I own the moment when I run through crowds, like a pregnant woman's breast milk leaked through her blouse. Busta Rhymes, look it up, homework. So even hearing the baby can cause milk ejection and cause milk to come. I think that's all I got. That's enough, though, isn't it? Wasn't that enough? That's a lot of stuff. This is like my favorite part. Because if you think about the evolution of this and the interaction between the baby and the placenta and the mom and everything that has to go right, I think it's pretty amazing. Other questions? Yeah. We still have a couple minutes.
At what point in the baby's development do the lungs stop relying on the mother's oxygen supply? The baby just...
Not until after birth. So the question is, when do the lungs start to not rely on the mom? So the baby's getting oxygen exchange from the mother all the way till it's delivered. But because it's underwater, it can't breathe until it comes out. So the surfactants there, the surfactants cause the lung maturation, but the baby can't breathe in air until it's actually out and out of the mom and the cord cup.
So even to the oxygen to the umbilical cord?
So there's no mixing of the blood, but oxygen passes from the maternal circulation to the fetal circulation because the baby has a hemoglobin with a higher affinity for oxygen, so it preferentially passes over. But it doesn't breathe on its own until it's out because it's underwater. Yes?
For the, you said the thyroglobulin binds up the free T4 so that the mother doesn't reabsorb it? Or it
It's not
doesn't make
that
it.
the mother doesn't reabsorb it, but what you're saying, but what you're talking about is estrogen not only stimulates TRH, which makes more TSH, which makes thyroid hormone, but estrogen also stimulates TBG.
The globulin.
TBG binds the thyroid hormone, so there's no negative feedback.
Okay.
So that the mother keeps making more and more and more and more thyroid hormone.
And the binding globulin doesn't affect how the fetus uptakes the thyroid
No,
hormone?
because remember, the fetus also has this high affinity thyroid binding globulin.
So it's
Normally as an adult, you have mostly TTR, which is a multiple site lower affinity binding protein, whereas TBG is the high affinity one. So typically, normally the fetus is actually grabbing the thyroid hormone because it has a higher affinity.
Before
And
it
we'll talk
gets
about
bound
this
up.
later. There's some toxins that bind to TTR and TBG, and so in some cases, mothers exposed to them, the baby gets preferentially receives things like PCBs because of the kind of the same system delivering the wrong. Yes.
How are the mother's antibodies introduced into the breast milk? Is it through the
Oh. You know, there are, I don't know the answer to that, but yeah, there are antibodies in the breast milk. There are vitamins, there are amino acids, there are antibodies in the breast milk. How they get in there, I do not know the answer to. And I also don't know how the antibodies, which are proteins, get across the digestive tract of the infant. And I've heard it's just the digestive tract isn't developed enough that it has the digestive enzymes. But how they get taken up from the gut, I don't know. I also don't know how HCG ends up in the urine, because the kidney is an ultrafilter. How do you get this big glycoprotein here? I don't know. Yes, hi.
I missed the point of E4. Why does it not use SHBG?
Well, if it doesn't induce SHBG, the point is then you have a hormone that has a higher free ratio. So it's more bioavailable to the mother. Because E3, E2, and E1, even though they have high affinity to the estrogen receptor, they're also mostly bound up by SHBG, and they induce SHBG, which might increase their half-life, but now they have lower bioavailability.
So E4 still induces the estrogen receptors.
E4 still binds the estrogen receptor, it binds ER alpha, correct. It does not bind ER beta or the ER gamma, specifically ER alpha.
When does HCG stop its effect on T4?
Well, only because it goes away. Because you stop making HCG after about the first trimester. It goes up, and then the corpus luteum dies, and it just stops doing it. So it can still do it, it's just that it's not around anymore. So you kind of have two peaks in thyroid hormone. One is regulated by that, and one is associated with the increase in estrogen. Right? Other stuff. Anything else? All right, so here's what we're going to do now. We got a baby. On Tuesday, we'll start growing. We'll grow the baby up. And then I think on Thursday, we go through puberty, right? What's the day today? Wait, how do we have midterm without puberty?
October 22nd.
Oh, is it all in the same lecture?
Yep.
Oh boy, you guys better come ready. Oh, that's right, we lost the lecture this year. You guys better come ready for it. We gotta go through puberty in one day.
Wait, and puberty is going to be on the midterm?
It could. I will have office hours on Wednesday. All right, I will see you guys.
Thursday?
I will see you guys on
Tuesday.
Monday office hours. And I'll